Good evening and welcome. Am I a bit I don't know if this camera is all set up correctly, but I'm a bit late tonight, so I wouldn't blame you if you gave up. But sorry about that. I hope I've got a mic here somewhere, so I hope the mic's working, and I hope everyone's well. Been a bit rushed off just recently, so I've come to this late tonight. When I say this, you know what I'm talking about. I'm talking about this live Q&A with plastic surgeon. That's me, JJ Staiano. When's that? Every Tuesday at 7 p.m. obviously. Oh, hi Shona, good to see you. Nice to see you. I missed you earlier. Sorry about that. It's all go today. I tell you, it's all go. So what we've got right here is some questions, and there's a list here, so I'm going to go through them. I've been away for the last couple of weeks. I've been on holiday. Can you see my tan? No, can't see it either. Antoinetta, I'd like to say hola back to you. Nice to see you. You changed your name, Antoinetta. Same picture, but I'm sure it's something different. Anyway, right, let's crack on. Enough of the niceties. Let's crack right on. So what we've got here is a question which says, this is something about, oh, I haven't got, anyway, about a minor op, but anyway, it doesn't matter. They're asking about how long. I hope you can hear me, by the way. Is the mic working? I'm assuming you can. Let's just assume you can. It's always funny to know what to say. I guess the thing to say is tell me if you can hear me, because obviously if you can't hear me, you can't tell me. I know what to do, obviously. What we do is we go old school. Can you? Oh, I better talk. Can you hear me? So, is the? Hi, Stephanie. Stephanie, what's that? Is that clapping? Can you? Is the audio working? Is the audio working? Yes. Okay. The audio. Right. Okay. Good. Good. The audio. Sorry. It's just I did anyway. I won't talk about I had a thing once about the audio, but anyway, never mind. We'll gloss over that. The audio is working good. So what we've got here, stitches. How long does dissolvable stitches last? People ask this sort of question. Thank you. The audio is working good. Varies. There's different types of dissolvable sutures. So they range from suture that lasts a week or so, which is a very quickly dissolving suture, which we would sometimes suture faces. Thanks, Stephanie. In children, or if you use the skin. In fact, I use it in the belly button when I do a tummy tuck. I use that quick dissolving suture in the belly button, and it's a suture that you see on the outside. The reason it's you use it in the skin usually, pretty much always, and you use it because you don't want to leave stitch marks. So you use it when you're doing an interrupted suture in the skin. It's not used that often. As I say, sometimes in children on the face if you're worried about having to take the stitches out. The reason that we don't use it very often is because it's unpredictable how long it takes to dissolve. And so if it takes a bit longer to dissolve, you worry there might be little stitch marks there. When I use it in the belly button, I stitch it in such a way that any stitch marks will end up inside the belly button. So there aren't actually any stitch marks outside the belly button. But I've gone off piste on this question a bit here. I've answered a different question. So how long does it? So yeah. So well, no, I'm still on the same question. Yeah, that's relevant. What I'm saying. Yeah. So there's some quick dissolving ones. That's called Vicryl Rapide. That one I'm talking about. And then there's others that take longer to dissolve, such as Vicryl. Without the Rapide bit, which takes a bit longer to dissolve. And then there's things like Monocryl and PDS, and there's lots of different types, and some, and basically, I guess the general principle, you guys don't really need to know this, do you? I'm telling you stuff you don't need to know. But anyway, I'll tell you anyway. So the principle is that the closer to the skin you go, the quicker dissolving they are. So the one that takes a long time to dissolve, something like a PDS or something, is something that you use quite deep. So again, with tummy tucks, you get quite deep layers. Takes a long time to dissolve. Hello, Zoe. Hi, Danetta. Who's Zoe? So it takes a long time to dissolve. So you use them deep. The reason for that is because when sutures dissolve, sometimes if the body gets annoyed at them and starts spitting them out, and you get little superficial infections. So as you get closer to the skin, they dissolve more quickly. The good thing about taking a long time to dissolve, is it holds the tissues together for longer and it keeps the strength for longer. The bad thing is that the body can start reacting to having a foreign body in it for too long and start spitting it out. So as we get closer to the skin, we put the quicker dissolving ones in. Bottom line, your question, how long for dissolvable sutures? So you're really talking about dissolvable sutures that are close to the skin. So when we're like, for instance, if you're having something on your body and we put a dissolvable suture just underneath the skin to close it, I would like to go back and do this question again, because I think I've not done very well on that answer, have I? Because all you're interested in is a dissolvable suture in the skin that you've had for a minor op. You're not interested in the history of dissolvable sutures. Anyway, so the specific answer to the question is it takes, I would say, a month or two. Okay, month or two. Which I just said that at the beginning. But caveat, the month or two is for the suture. The suture gets dissolved by being in contact with the water. The knots, which are at either end usually, because it's usually a subcutaneous stitch, you can't see it on the skin, but it's usually underneath the skin. There's a knot on either end of the stitch, and that takes longer. So that can take a few months for the knots to dissolve. Similarly, if you've had something like a breast reduction or a tummy tuck or something like that, where there's quite a lot of interrupted dissolvable sutures as well as the one in the skin, sometimes you get little red dots where those interrupted ones are. And because of the knot, it can take a few months for that to dissolve. That's why a few months after a tummy tuck or something like that, you'll sometimes get little bits of suture spitting out. Which I guess, yeah. Oh, sorry about that. I think I didn't answer that well. But anyway, that's how long. I would like to know the contents of the question, really. What were they asking for? I think I can't remember where I got that question from. Anyway, there you go. Good. That's how long they last. Dissolvable sutures last. It varies, but a couple of months for the ones that are close to the skin. Unless they're ones in the skin, like you can see them, in which case it'll be, a week or so. Okay, move on. BMI, body mass index. Body mass index, so apparently we've had a few questions about this, about what body mass index do I need for surgery. There is no absolute. In the NHS, you'll find there's an absolute. And this is normally body contouring surgery we're talking about, not so much mole, cysts, lumps or bumps. There's not really a BMI for that. But it's for body contouring, so in bigger operations, tummy tucks, mastopexies, breast reductions, big operations, there is a BMI guideline simply because the complication rate is higher if the BMI is higher. It's a bit like smokers. Got nothing against people who have got high BMIs or nothing against people who smoke. That's absolutely fine. But it can increase your risk of complications. So that's the reason for this. We're not being sort of discriminatory against people. It's because the complication risk is higher in people with high BMIs, smokers. But I'm not going to talk about smokers because that's not the question. So I'm going off beast again. So BMI is the question. So I normally work on a BMI of 30 is the number that I normally work on in my own mind. And I'm looking if the BMI is below 30, it's good. If the BMI is above 30, it's not so good. But it's not an absolute thing. So the main thing is, I hope you're well. The main thing is you've got to be stable and comfortable with your weight. Well, no, there's two things. First of all is the absolute value of the BMI. So if it's way over 30, if it's 40, then I think you've got a very high risk of complications and you will be better off losing weight prior to having surgery. However, if it's just a little bit above 30, or even, to be honest with you, even if it's below 30, you've got to be stable and comfortable with your weight. So if you're not stable and comfortable with your weight, you should do that first. You shouldn't really have body contouring surgery like a tummy tuck or breast lift or something like that when your weight is changing. Because the reason you need a body contouring surgery is because the skin has been stretched, usually by putting on weight or having children. Those are the two things that can do it. And then when the stretching force goes, you're left with this redundant skin. So if you lose weight after surgery, you might be left with more redundant skin. So you really need to be stable and comfortable with your weight. number one, because your complication rate will be less, but number two, because you will have a better result, because I'll be able to make the skin tighter if you've lost your weight first. If I make the skin as tight as I can and then you go on and lose weight, I might have been able to make the skin tighter if you lost the weight first, and you've had a better result because your complications would have been less. So all in, better result if your weight is lower. But BMI is the ballpark. BMI of 30 is the ballpark we work on. If you don't know what BMI is, it's the body mass index, kilograms per meter squared. So it's your weight in kilograms divided by your height in meters squared. That's how you work it out. I think there's sort of things on the computer to work that out all over the place if you need to work that out. So that's the BMI. Good. Revision on scar or scalp. This patient has got a scar on the back of the scalp, hair transplant. They've taken a piece of the skin, and the scar has stretched, and he doesn't like the stretched nature of the scar and is wondering if it can be revised. It's tricky. The reason scars stretch is because they're under tension. And the scalp is in place where the skin is under tension. And unfortunately, to revise it, it will be under tension again because it's stretched quite a lot. And so in your mind, you always think, yeah, I can make that better. Yeah, I'll give a much better scar. And you cut it out and you stitch it up and you give a much better scar. You think, I've done a great job. I'm a great guy. Aren't I fantastic? But then over time, it stretches again, in my experience, because you're stitching it tight. And some places are just prone to it, and the scalp is one of them. If there's a problem, if the wound broke down, or if there's an infection or delayed healing with the scar, with the wound, when you first had it done, there might be an option to think, oh, well, maybe that was the reason the scar stretched. But it's probably because the scar was closed under tension, and if we revise it for you, we'll be closing under tension again. And so the worry is that it'll stretch again. The hope is it would be better. So we might be able to make it better, but I would put it like that rather than saying we're going to give you a fantastic scar. It might be better. It will be better to start with, but then it can stretch over time. And so be a bit careful dealing with stretch scars because they can stretch again. The other problem with scars on the scalp, it's fine if you're a woman with long hair and everything because you can sort of cover them. Because a lot of people say, oh, I'm having this cyst removed and we're not going to be, hair on it because you don't get any hair on a scar. The problem with men is when men, especially if your hair is a bit longer, like this, I think you can see that hair is quite long. I think you'll all agree. Then it can hide the scar. There's a scar there. But if the hair is a bit shorter, non-existent there. But if the hair's shorter, where you crew cut sort of really short, then you can see the scar. The scar all of a sudden becomes much more obvious. And so this chap's got quite, he shaved his head, but if he did grow, and so the scar's very obvious, but if he did grow a bit of stubble sort of thing, it would be more obvious the shorter the hair is because there's sort of stubble scar. And then, so it's really hard to make that better. Even if it was a hairline scar, it would show on the scalp, on the sort of really closely shaved scalp. So that's a really tricky, that one scar on the scalp. And my feeling is we haven't seen this patient in the clinic. He's just inquired on the email. I don't know if he's here tonight. Hello, if you are. But my feeling is I would probably be inclined to leave it, to be quite honest, because I would worry that we'd revise it and make it a little bit better, but not that much better. And in your mind, you're probably thinking, I'm going to get a plastic surgeon to revise my scar and it's going to be beautiful and no one's going to be able to see it, which is not the case. So it's managing expectations. So we've got to... so that'd be my expectation of that. This is a good one. Endoscopic diastasis repair abdominoplasty. Woo woo! Endoscopic diastasis repair abdominoplasty. Well, we've had a diary about it. So if you know what it is, please write in on a postcard, and we'll have a prize draw. So we've had an inquiry about it, and the person who inquired might be there. So if you're there, thank you for that inquiry. Very interesting. So this is an interesting thing. So what is that? Well, endoscopic diastasis. So diastasis repair is basically your rectus abdominis, your six-pack. You see people with a six-pack. I would show you mine. The six-pack, but I might get in trouble with the Facebook and the servers being inundated. So the six-pack is what the six-pack is. There's that rectus abdominis muscle. They're two muscles side by side, and they've got those tendinous intersections, those lines which actually give you the six-pack. But anyway, they're two muscles that go straight down in your tummy. And when you have a diastasis of your recti, the rectus muscles become splayed apart. And that, again, is putting on weight and having children, stretches the tummy, the intra-abdominal contents, those muscles get splayed apart. Then people will do exercise and work out and things and can strengthen the muscles. But if the muscles are splayed apart, then part of a tummy tuck is to bring the muscles together again. And that's a diastasis repair. Endoscopic diastasis repair refers to making endoscopic is like a telescope, keyhole surgery, making keyhole incisions to repair the rectus muscles. And I guess it's possible. I mean, it must be possible because the patient's asking about it. So you can make keyhole incisions to repair that muscle. It's very rare, not unheard of, but it's very rare for people to have just a diastasis of the rectus muscles without having excess skin, because the common cause of diastasis of the rectus is the muscles have been stretched by the intra-abdominal contents stretching, and that usually stretches the skin as well. So there's usually excess skin at the same time. So you usually need to have an abdominoplasty as part of it. This person asking presumably doesn't need an abdominoplasty and just wants, because the endoscopic repair is keyhole surgery. Keyhole surgery is just tiny incisions, so no skin is removed. So there'll be no skin tightening if you do endoscopic repair of the diastasis of the rectus. Oh, Rebecca's coming with a question. So no skin tightening with that. So it is something that is possible. I wouldn't do it personally because I don't do endoscopic surgery. I don't do endoscopic or laparoscopic. Have you heard of laparoscopic when they go into the sort of belly, like the general surgeons do gallbladders and things? So that would be a general surgeon who does bowel sort of surgery, and they are familiar with doing endoscopic things, and they're familiar with repairing hernias and what have you. So a general surgeon would be your point of call if you're interested in endoscopic diastasis repair of the rectus. Endoscopic diastasis repair, abdominoplasty doesn't make sense. I know I wrote it there. I think I wrote it there because the person, that's what they inquired about. Because an abdominoplasty is the skin removal and tightening of the skin. So endoscopic diastasis repair will be something on its own because it's endoscopic. An abdominoplasty is when you take all the skin out and tighten the skin. So that's a sort of separate thing. So if you do an abdominoplasty, you can see the rectus muscles there, and they're there for all to see, and then you can repair them. And that is a fantastic question leading me on, as if this was planned. Rebecca, you are a legend, because you've asked, how do you know if you need a mini tummy tuck or a full tummy tuck? That is an excellent question, because that is related to that last question. So it's almost like we planned this, Rebecca, almost like this was a professional show. After 3 sections, I think I would like 1. Yes. Okay. Very good question. And really, it's how do you know? It's not. I think about plastic surgery. It's not really. There's not that many set things, and a lot of it is opinion and judgment and what have you. But I tell you, in general terms, most people need a full tummy tuck. I think that's fair to say. A full tummy tuck. When you talk about it, mini tummy tucks are shorter scar, quicker recovery, cheaper, no scar around the belly button. Sounds fantastic. I'll have a mini, please. Give me a mini all day long. The problem is less of a result. And when you look at the result of a mini compared to a full, it does give less result. A mini only really fixes the bulge above your cesarean section scar. It is very good. If you've got a bit of a bulge above your cesarean section scar, a mini is really good at that, and a mini will fix that, and it gives you a scar which is slightly longer than your cesarean scar, no scar around the belly button, and it just tightens that skin. Might pull your belly button down a little bit, but no scars. When you're in a bikini and things, there's no scars on your tummy, and that is good for those patients. But it doesn't really do anything to the sides out here. And it doesn't do anything above the belly button. It doesn't tighten any of the skin above the belly button, because the belly button, you can't get any pull. A full tummy tuck, all of the skin from the belly button down to your cesarean scar, all of that skin gets removed. And then the skin that's from the belly button up to your rib cage gets pulled down to become the whole of your abdomen. And then your belly button pops out through a bit of that skin. So you get a scar around the belly button and a much longer scar, much longer than your cesarean scar, in a similar position to your cesarean scar. Hi Tracy, good to see you. Glad you can make it. So it's in a similar position to your cesarean scar, but it's much longer than your cesarean scar. But it does contour the whole abdomen a lot better, the full tummy tuck. So there's no real obvious answer. It's really for after examination and really patient expectation, what outcome you want, because obviously you want the best outcome and the best tightening of your skin and the best, best for your tummy. But then also you want the shortest scar, you want less downtime. So you've got to balance the mini and the full. There's often, well, we would often give you an opinion on it, but it's like sometimes it's like, well, you could have a mini, but it's going to give you less of a result, but it'll be less money and less downtime and less scarring. And you might think, actually, you know what, on balance, I'm up for that. Or you might say, actually, no, I don't. If I'm going to pay that much, because a mini's not that much less than a full. So if you're going to pay that much, a full gives a better contouring. In my experience, a full is the more common one. But you need to have a chat about what's right for you. And yeah, Tracy's given me, I think that's clapping, is it? And Sarah, I hope it's clapping or waving, is it? What's going on with the names? Because that photo doesn't look like Sarah. That's not Sarah Louise. Anyway, I will get into this. Have the names gone funny on Facebook tonight or what? Or have you changed your name? You got that? Anyway, right, what am I doing? Oh, look, Rebecca's back in. Rebecca's back in. Back in. Another great question, Rebecca. Oh, we have to. Couldn't have planned it better, Rebecca. Great question. I'd love a full one. Thumbs up for that. Sorry, where was that? Rebecca. How long after having a C-section can you have one? Very good question. Very good question. Couple of things at play. First of all, you've obviously had a C-section, so you just had a child, so you've got a small child, so you've got to bear that in mind. There's a small child in the mix, and the tummy tuck is quite a big op. And sorry, Sarah, it's just that I thought I knew you from your photo. That's why I'm saying about the names. But anyway, sorry, maybe you just look like a patient of mine. Sorry. So I thought the name. Anyway, I'm going above myself. So there's a couple of things in play. Obviously, you've got a child around, so you've got to take that into account, because a tummy tuck, mini or full, is a big deal. Full is a bit of a bigger deal than a mini, but they're both a big deal. So the answer to that question is, I would say minimum 6 months, ideally 12 months. Couple of reasons for that. Number one reason is your tummy, once you've delivered the child, will recoil. The skin does recoil to a greater or lesser degree. So you might say, oh, I know I'm going to need one, but it might recoil to a degree. So you have to give it a chance to recoil, to see it, to make it as good as it's going to get. To see, you might not need a tummy tuck, or you might need a mini instead of a full, So the longer you leave it, the better, to give it a chance to recoil. Also to get the weight sort of stabilized. Often the weight's a little bit up and down after you've had a child. And again, referring back to the BMI question, you want to get your weight stabilized before having this sort of surgery. But the other thing you've got to think about is the fact you've got a child. It's difficult. You say, oh no, I've been lifting for 6 weeks. If you've got a child, you've got a 6-month-old child, you can't not lift them. So you have to lift them. I knew it. I knew it wasn't Simcock. Right. Thank you. So you got a child. So you really need a child. You really need to give yourself time. So either a year, your child is usually running around, and well, maybe not running around. I don't know. I think they're doing a bit more mobile a year than earlier. Obviously, they're bigger and heavier, but they're a bit more mobile, maybe starting to walk and stuff. So I would say a year is a sort of good time to wait. Minimum, no maximum. Wait, but I know obviously people are keen to get it done. But I would say 6 months is minimum. 6 months is minimum, and a year is reasonable. And 6 months is really just sort of an absolute minimum. God, yeah, is that clear? Sarah, I knew it wasn't Simcock. I knew it wasn't. So thank you. Right. I knew I recognised you. Anyway, good to see you. Good to see you. And congratulations. Congrats. Right, going on. That was, I'll tell you what, Rebecca, you did the double there, and that was very impressive. Those double questions, which were very relevant, tied right in with the whole plan. We got a question here, pain during and after inverted nipple repair. I don't know when this question came in, so I don't know if this patient's had the nipple repair by now. Oh, multiple collapse. But anyway, I'll answer it anyway, because I've said I would. Pain during and after inverted nipple repair. Well, can we open it up to any sort of, well, obviously, well, no, we'll keep it niche. Yeah, inverted nipple repair. I mean, obviously, nipple is not a great place to have local anesthetic. It does sting. It does bring a tear to your eye. It's a very sensitive area. So the anesthetic does sting, and that is the worst bit, the anesthetic. It stings for a seconds when you have the injection. You have to have an injection. You know, it's a local anesthetic, meaning the injection goes locally where we're doing the surgery, which is obviously in the nipple. So that is something that is a necessary evil, that there is an injection there. So that is a bit uncomfortable. Once the injection's in, you should be fine, although you will feel movement and touch, but you don't feel anything painful. If you do feel pain during the surgery, then just say, and we'll put a bit more local in. You shouldn't feel pain during the surgery. You will feel touch, you will feel movement, that is normal. But the pain fibers are smaller than the movement fibers, so they get anesthetized before the movement fibers. So during surgery is not painful. A lot of people say, when's the anesthetic wear off? You say, it wears off in a few hours. And they go, oh my God, you know, I'm going to be in agony in a few hours. It's not true. The painful bit is having the surgery done. Inverted nipple repair in particular is not that big an operation. It's incision's quite small. There is some sutures required, and you do have to sort of divide the ducts, so there is a bit of thing to it, but it's not that invasive. So the painful thing is actually doing the surgery, and the local anesthetic covers you for that. Once the local anesthetic wears off, I hope it wouldn't be too painful. It's not like you're going to be walking down the street 4 hours later and suddenly, oh my God, I feel like I'm in shock. You know, it's terrible pain. It's usually not too bad, the pain, and just normal painkillers, ibuprofen, paracetamol. You sort of know you've had something done. It'd be about uncomfortable if you go back to work and things, but you might, you know, you should be able to sort of go back to work and stuff. Maybe next day, maybe give yourself a day off. But yeah, it's a little bit uncomfortable to have it done for the local, but after that, it should be fine. It's you know, like any local anesthetic case, you know, they usually are a bit uncomfortable afterwards, as you might imagine, but because you're not sort of closing things tightly or stitching things under tension, you know, when you remove moles and stuff, sometimes it's a bit tight and feels a bit tense. There's none of that with this. So hopefully it's not too bad afterwards. So I don't think pain's a massive feature of it. And one thing, if you're worried, is that you can always talk to a previous patient. Don't take my word for it, because I'm going to say, well, I'm not. I am hopefully going to be honest, try and be honest. But you know, if you know, it's always good to talk to someone. So we do offer people to talk to previous patients. So I'm just going to put this up on screen. Sarah Simcock-Ney-Bowman, love your work. Thanks, Sarah. That's what we need. That's the sort of spontaneous publicity we need. Tracy says, still struggling at B-lights. And so I am going to go to the BARPS meeting. In fact, I'm going to a couple of meetings. I've got a meeting in Belgium in a couple of weeks. And I've got BARPS meeting next month, the Plastic Surgery Association meeting. And the B-light people will be there, Tracy. So I will talk to them. I spoke to them before. The problem is when you speak to them, they say, yeah, they got it in all the hospitals. They're really easy to get in the hospitals. And then you speak to the hospitals and they say, we haven't got them, they're difficult, they're new, and they're a bit funny about it. So yeah, I think you know, the problem with B-lights is we are all this risk averse, and everyone's like, oh, they're new and everything. But I think you know, yeah, well, if the hospital, yeah, good. So I'll talk to them at the BARPS and at the CAT-BAS meeting in Belgium in a couple of weeks' time. Because I'm actually going with Polytech, who actually make B-light implants. So there you go. I should be able to, or at least, yeah, they're together with Polytech somehow. We've got a big one here. Big one. Rebecca's back in. Rebecca, you've gold star tonight. Look, come on, guys. What are you doing? You're letting Rebecca take the whole limelight. You know, Tracy's had a go. Sarah's had a bit of, you know, the getting married stuff, but Rebecca's well in. Coming to see you next year, as had capsular contraction and would like to replace an uplift. Which implants would you recommend to help stop capsular in the future, and would it be better behind the muscle as less contact with tissue? Okay, good question. Flipping heck, Rebecca, you've nailed it on the tummy tuck questions, and now you're going on the breasty questions. Yeah, capsular contracture is a bit of a nightmare, as you are finding, and it's a bad thing, capsular contracture. And my recommendation is, if you have a capsular contracture, polyurethane foam implants, which are made by Polytech. They're the only company that make them because they've got a much lower rate of capsular contracture. However, they're a bit controversial, and there are certainly, like anything, like I was saying, what was I saying about the pros and cons? What was it? Dissolvable sutures, no, BMI, was it? Anyway, a bit earlier on, seems like years ago, a bit earlier on in this broadcast, I was talking about pros and cons of something. Can't remember what it was now, but there's pros and cons of, was it the BMI? I think it was a BMI. There's pros and cons of the polyurethane implants, and one of the pros is they've got a much lower rate of capsular contracture compared to silicone implants. But there are cons, which we can definitely go through, and you know, we've got some details I can send you about that. But there are definitely cons of them, but they are so if you're specifically worried about capsular contracture, they are the ones to have. The muscle thing is true. Capsular contracture is, you say there capsular contracture is better behind the muscle, has less contact with tissue. It's not really because there's less contact with tissue. Capsular contracture is scar tissue forming around the implant. The capsular contracture is your body's reaction to the implant, and that happens wherever they are. Now, it manifests itself as feeling hard and looking unsightly. And when you have the implant under the muscle, there's an extra layer on top of the implant, which makes it look less unsightly and feel less hard because you've got the muscle on top. So when you're feeling muscle before you're feeling the implant. So capsular contracture does present itself later when implants are under the muscle. So if you didn't want polyurethane implants, then I think polyurethane implants is probably the best way to reduce capsular contracture, but also putting them under the muscle is another thing that you can do if they're on top of the muscle and you can see the edges, feel the edges, particularly you've got things like rippling and things. Putting them under the muscle does give that extra layer of cover and makes capsular contracture present later. But I hate to be like a moaning mini. Moaning mini is the wrong word. I hate to be a sort of negative guy, but like anything, like the BMI thing and like the polyurethane implants, there's bad things about putting them under the muscle. So again, you've got to weigh it up. When you put up the muscle, they can be high, they can be wide, you can get animation deformities. So there are bad things about putting under the muscle, but there are also good things about putting under the muscle because it gives you that extra layer of cover. So it's a balance. This whole thing, this whole job is about balancing risks. And we had a thing on Facebook the other day, I don't know if you saw it, about that lady who died in, I don't know where she was it Turkey or anyway, it doesn't really matter where she was. She had buttock augmentation and she died, which is so rare. Actually, death after buttock augmentation isn't rare, but death after cosmetic surgery, well, it is rare, but buttock augmentation is known to have a high fatality, much higher than any other cosmetic surgery. But I'm getting off the point. The point is there's risks with all surgery. I don't know if I should start that, but there is risks. And everything's about a risk and a balance. And if someone says, look, could bad things happen if I have surgery? You'd be like, yeah, they could. But there are bad things that can happen with anything. There are bad things that happen when we go out to across the road or to drive down the motorway. And we just got to balance the risk every time we do stuff. But if you specifically ask, is there a risk with me driving home tonight? Yes, there is a risk. But what am I going to do? Stay here? No thanks. Oh, dude, terrifying here at night, I'll tell you. It's a balancing of the risks. Stephanie's in with a late one. I had capsular contract. Oh no, that's Rebecca. Stephanie, I had Jonathan. Oh God, I'm all over the place. Did my capsular implant replacement? Yes, I did. Pulling it, and they're amazing. So, oh, look at that. Look at that. As if I'd planned it. Tonight is going. I should do it late every night. It's going better than ever. Stephanie, you're a legend. Thank you very much. If I could I can't thumbs up this, but I will thumbs up at my convenience later because I can't get on this thing because I've got the thing when I put it up like that. So that's not, I can't put the thumbs up on. Thanks, Stephanie. Thanks for that vote of confidence. I'm very grateful. And can't forget your case, Stephanie. That was an interesting one. And I'm glad, it looks great. So what we got here is Rebecca's back in. Good. I had capsular contracture after pregnancy. It's not painful anymore. I heard that in America they use some sort of mesh over implants to help stop it. My implants are 9 years old, and I'm sure pregnancy has something to do with it. Okay. Yeah, pregnancy and capsular contracture. God, is that a risk factor? I don't think it is, Rebecca. I don't think it is. But, you know, what are you going to do? Not get pregnant? You know, what's more important? I don't think it is. It might be. We don't really know much. Well, I shouldn't say we don't know much about capsular contracture. There's loads of things that are, it's multifactorial capsular contracture. There's loads of things that there's no one thing that causes it. I mean, it is scar tissue, which is normal. Scar tissue is normal. There's loads of things that exacerbate it, and there's loads of things we do to reduce it and minimize it. But unfortunately, it is a problem. In America, they use some sort of mesh over implants to stop it. Interesting way of putting it. They do use mesh, and we use mesh here. Dermal matrix and mesh is like it's a dermal substitute. So it's the dermis is the bit underneath your skin, and it basically gives another layer of cover over the implant. And it's a bit like putting them under the muscle, but without putting them under the muscle. It gives another layer of cover. So mesh is good. Mesh is good to support breast implants. Is good to give extra layers of cover over them and what have you. And I think they do use it a lot more in America than we do here. One of the problems with mesh is that it's expensive. That's a big problem because a lot of this stuff is done in the private sector. If you have stuff, you know, when you're doing stuff in the NHS, like reconstructions and things, it's still expensive there, but, you know, I think you'd use it more. But for a cosmetic augmentation, when the costs are passed to the patient, it is an expensive thing to be using. And it's only really in revision cases and people have got real problems that you really need to use a mesh. And a mesh just, gives another layer of cover over the top in the same way that a muscle would do. A muscle would do it better. The problem with the muscle is submuscular. The muscle comes like that. And it's sort of like it sort of goes into your arm and it goes across like this. So this bit of the implant is not covered by the muscle. So the mesh, you can use the mesh to get total cover by putting the mesh into this part to cover it if you've got cover here. Usually the problem with cover is in this area because it's sort of cosmetically sensitive, but the mesh is another option. And of course in America they can't use polyurethane foam implants, so obviously they've got to use silicone implants. So I think that they're looking for other ways. But mesh is out there, and it's not just used in America. We use it here. But as I say, we don't use as much of it for cosmetic breast surgery as they do in America. Stephanie, big up yourself. I'll see you on Friday. Yes, I will see you on Friday. Good. Can't wait. Looking forward to it. Should be a good day. Sarah, I had uplifts and implants 5 years ago. Had another baby nearly 2 years ago. Had no issues so far. How would I be able to tell if there was a problem with them? I.e. capsular contracture. So far, so good. You know what, Sarah? Don't go looking for it. A lot of people say, have I got capsular contracture? I hope that, Sarah, you know that there is you're in the system. I hope I'm following you up still. Am I? But you know you can come back if I'm not. So come back anytime. I offer everybody a yearly follow-up. I would have offered you a yearly follow-up. So by all means come back. But with the yearly follow-up, I'm just checking on things. I'm not looking. If you haven't got a problem, I haven't got a problem. So it's really up to you as to whether you feel that there is an issue. And if you feel that there's an issue, then then there's an issue. And if you don't feel that there's an issue, then there's not an issue. So, it's really up to you to decide whether you've got your implants feel hard or they or if they are uncomfortable, then you've got a problem. So I think if you have had them for 5 years and you've got no problems, then I think I don't think you should worry about it. I think you should just enjoy them and don't go looking for capsular contracture. Don't let someone tell you you've got capsular contracture and you should have something done about it. I think it's something really for you to say, I've got a problem and I would like to have a something done about it, because if you haven't got a problem and if they don't feel hard and if they look fine, then you haven't got a problem. If you feel like you've got a problem, if they feel hard or there's any issues, come and see me and we can talk about it and see what the problem is. It's not really for you to diagnose capsular contracture and things. It's just symptomatic. It's based on symptoms. So the patient's got no symptoms. If you say, how do you feel? I feel fine. You've got no problems with your implants, then that's fine. You know, that's it. If you have got symptoms, okay, well, let's have a look what this, you know, then we can examine and see what's going on to see what the problem is. But it's not, don't think, oh, you've got to look out for capsular contracture and make sure you diagnose it and come and get it seen too quickly, because the answer with capsular contracture is the longer you leave it, the better. Even if you have got capsular contracture, the longer you leave it, the better. Because once you start doing stuff, then you create more capsular contracture in the next set of implants. So that goes with you as well, Rebecca. So if you start doing surgery on people with capsular contracture, you create more capsular contracture. So you only do surgery once it's really bad. So you wait until it's as bad as it's going to be before you start messing with it. Oh my God, we've got things coming in thick and fast now. Junie, good evening. Good evening, Junie. What do you think of the eyebrow procedure, and do you do it? Do I do the eyebrow procedure? Junie, what's the eyebrow procedure? Sorry, I don't know what the eyebrow procedure is. It's good, isn't it? Eyebrow. Is it something to do with meshes and things? Do you know? Can you elaborate on that, Junie? I'll come back to that in a minute. Thank you for my before and after. I forgot how amazing my transform was. Oh, thanks, Sarah. Glad you. It took us a while to get those photos to you. Sorry about that, but thanks for persevering. Sarah, I haven't been for a follow-up probably since a year after surgery. As all good. Just wondered if I was to get checked out and not miss anything. Just wondered if I was. But yeah, like I say, still, yeah, Sarah, come along. Both Sarahs, Sarah with one S and Sarah with two S's. Come along and come for a follow-up, because I like to keep an eye on people and I offer everyone a yearly follow-up. So come along for a yearly follow-up and we'll have a chat about all this sort of stuff. And yeah, we'll get it done. Okay, Junie, it's an internal bra made of. So yes, I know about these things. There are a few of them. Yes. So what was your question? What do you think of the eyebrow, and do you do it? I think it is a good idea, Junie, and I don't do it. I did a blog post about this a while ago. The internal bra, internal mastopexy, all this sort of stuff. Yeah. And it's a good idea. And what it's trying to do is it's trying to maintain upper pole fullness, particularly for a mastopexy or breast reduction. Because with the mastopexy and breast reduction, the breasts start like this and everyone's happy, and then they settle. And they settle to what I would call a more natural shape, more concavity in the upper pole. But some people want more fullness in the upper pole. Now, if you use implants, you can get fullness in the upper pole. But if you don't use implants and you've got your own breast tissue, then the breast tissue will tend to settle. And so that is a problem with breast reductions, and it is a problem with mastopexies, with breast lifts. So the breasts settle, and people think, I don't like this, and I'd rather it to be fuller. And the things that you're talking about, these internal bras, are trying to address that problem. And there's a few of them. There's like a cone thing that you have to put in and maintains the shape. And there's this thing like you're describing, the hammock that is anchored into the ribs. Now, there are some problems with them. Obviously, they have to be anchored to something that's solid, because if they're not anchored to something that's solid, the whole thing will just droop. So that's why you have to use bone anchors into the ribs. That can be a little bit uncomfortable. You do have to undermine quite a lot to get the thing in. And I worry about infection, because you're putting it in a foreign body. Now, I know that when you put in a bra, when you put an implant in, you're putting in a foreign body as well. But the implant is all covered with the breast tissue. The whole point about this is it has to be got to be relatively close to the skin, because if you put it too deep with too much breast tissue the other side of it, that breast tissue will sag. So it's got to be relatively superficial. So I worry that if you do get infection, it can cause problems. I worry that you'll be able to feel the edges of it and things like that. And because it's a permanent mesh, then you worry that it will always be like, because again, if it dissolves, then you worry that the recurrence, the problem will recur. So there's a lot of issues around it, which I haven't really embraced. I'm not saying it's a bad thing, because some people haven't embraced it. And you know, if they're getting good results and not getting complications, then that's fine. I'm not saying it is a bad thing. I have spoken to them at the meetings when they talk about it, and they make out it's great, and they show great results. But that's what worries me, and that's why I haven't embraced it, and I don't use it, because I don't think it's there yet, and it's certainly not widely popularized and widely used by my colleagues. bit like the B lights, were all of it. Oh, you know, new thing. Doesn't mean it's bad. In 20 years' time, we might all be using it. But yeah, there are a few potential complications with it, Junie, in terms of infection, pain because of the bone anchoring, being able to feel the prosthesis. So there are things that worry me. And so what I do is I say, look, you're going to have a mastopexy or a breast lift. It will make the shape significantly better, but over time it will settle and you will get a bit of a concavity in the upper pole, which you can't really do anything about unless you're going to have an implant, which will make the breast bigger, which a lot of people don't want. And so I would say, look, you know, the main thing about implants is making the breast bigger rather than giving that fullness in the upper pole. I think that's the main benefit of implants. So that's the way I treat it, and that's my view on it. But it doesn't mean it's the right view. As I say, there are people out there who may be using it and maybe getting good results with it. So that's where I am on it. That's my position. Rebecca, I canceled contract in 2012, but I just left it. Will you see next? We'll see you next year. And you're very welcome, Rebecca. Yeah, you're absolutely right to just leave it, Rebecca. Bang on, leave it as long as you can, I say. And if I see you next year, I'll tell you the same thing. Leave it as long as you can. The longer you leave it, the better, because once your clock will start ticking on those ones. So, yeah. Wow, is this time better than the other time? God, I felt like I'm starting late, but I'm bald. That was good, wasn't it? That was a busy one tonight. That was better than ever. Junie, thank you. Thanks for elaborating on your eyebrow. And yeah, thank you all for that. That was fantastic. Been off and a fantastic one to come back on. I need to go home. Right, okay. So, put my light on. It's a bit dark back there, isn't it? Thank you for being here, everyone. I really, really appreciate all those comments. Fantastic. That's lovely. And I will do the thumbs up. Same time next week. Maybe I'll do this time. Actually, I'm looking at changing the day and stuff. Watch this space. Watch this space. Not gonna start over there. Oh, start over there. So yes, good. Thank you. And that is, I'm going to check myself out of here. And thank you all for those comments and those stuff that you've been saying. And I will see y'all next week. And I will end myself here. Good night. Have a nice evening. Sleep well. Oh, back to the Yorkshire Vet. What's the Yorkshire Vet? I don't even know what that is. Don't tell me there's something on TV that I'm missing. Right, yeah, go back to the Yorkshire Vet. I'm assuming it's a thing on TV. Maybe there's a person, maybe there's a Yorkshire Vet there. Anyway, what you do in your personal life, Junie, totally up to you, and all power to you. Thanks for your questions, and good night.